Morning, everyone, and welcome to the last session of our Value in Health Week. I'm really pleased this morning to be joined by three very, very senior managers within Welsh NHS and Welsh Government who are going to have a chat with us this morning around the opportunities really for value in health, value-based healthcare, and helping us transform the Welsh NHS over the coming years and what the future holds basically for value-based healthcare in Wales. And as many of you will know, Value in Health has grown really from a grassroots movement in Wales with clinical teams and financial managers really using this as a lens to make transformational change. But we also know that unless we marry that up with the top-down approach, then it's very difficult for us to sort of really accelerate away with this transformational agenda. And I think we're really lucky in Wales because we do have an integrated health board system. We do have a system where we are able to plan for population health. So despite the very many challenges that we face in the system at the moment, whether that's financially with workforce shortages and so on, we do have, I believe, some real opportunities in Wales to really make progress with this. So I'm going to introduce you to our guests now. First of all, we have Nick Wood. Nick Wood is not the old England rugby player from Gloucester. He is, in fact, the Deputy Chief Executive for NHS Wales. Then we have Samia Said Edmonds, MBE, who is our Director of Planning in Welsh Government and NHS Wales with a very long history of healthcare management, of course. And last but definitely not least, Jeremy Griffith, who many of you may not know, started life as a physiotherapist. I think that's right, Jeremy? No? I've got that wrong. Okay, well, anyway, never let truth get in the way of a good story. He does have a clinical background and many years of experience in both the public and private sector in healthcare. But first of all, Nick, I want to come to you, if I may, to get your reflections. I suppose you've watched the value-based healthcare journey over the last few years, the opportunities it gives us and how it might help us solve some of the challenges we face in the coming years. Thank you.
Thanks, Sally. And it's the first time ever I've been compared to a rugby player, so I'll have to look that up after when I finish this meeting. But no, thanks for that, and thanks for the introduction. And I think what you've probably described already in your brief monologue around the challenges that we face in the health system in Wales is probably reason enough, really, for us to focus on value and how we can get best out of our pounds of taxpayers' money that goes into the NHS on a daily, weekly, monthly and yearly basis. But we do face some particularly unique challenges currently, whether they are financial or demand driven or in terms of the long-term health of the population, and all of those challenges really come together in how we view our healthcare system through a lens of being able to provide the best patient experience that we can, the best value for taxpayers, but I think more importantly, how we can get best outcomes for people in terms of the healthcare that they receive. And so I think in tracking the journey, as you described it, I think of value in health in Wales, it's quite interesting to see it has moved a little bit, I think, from being solely focused through that finance lens. It was very finance driven at the beginning, I think, and what we see now is a much more focus on best practice, best pathways, best patient experience, and elimination really of the variation that we see right across the system, and trying to move to a system where you get the same experience wherever you are in Wales, or whichever clinician you may see on a particular pathway or journey through the service. And I think that's really important if we're to meet some of the challenges we've got, because not only is it elimination of that variation and difference that we see in each of the pathways, but actually elimination of some of the steps, and I suppose you call it sort of almost like service bureaucracy that we go through to get from A to Z in terms of the pathway, and how can we remove some of those steps effectively and efficiently so that the patient goes through seamlessly and in a way which is effective and efficient to their needs. So that's how I see it landing in terms of meeting the challenges. And of course, if we can deliver all of that, it will deliver a much more sustainable and value for money service in general. But also, I think it will enable us to make clear the assessment of demand and capacity that we've got and that we need as we move forward, so that we can tailor the service to future needs, not just react to the current challenges and demand that we've got in the system. So I think there's a lot to learn from this, and that's how I see it sort of playing out. And it's been really useful, I think, to embed value within the sustainability, the value and sustainability board that we now chair through Welsh Government and with health boards, and also in terms of the NHS executive and making it an integral part of how we use the executive to oversee the work of the NHS and deliver some of the policies that we've got. So I'll pause there, Sally, and obviously you'll want to bring in some other colleagues.
Thank you, Nick. That's great to kick us off. Samir, can I come to you next? Because clearly being able to plan for population outcomes is probably a real advantage of the Welsh system. Could you give us some of your reflections on that?
Yes, certainly. Thank you, Sally, and thank you for the opportunity to join you all today. I know you didn't compare me to a rugby player. I don't think I share my name with any rugby players, but I do share my name with a graffiti artist in New York, which sounds far more exciting, doesn't it? But I was genuinely excited when you asked me to be on the panel today, not just because it's a great opportunity for me to be here with you, but also because it's an opportunity for me to learn from the audience and the questions that will get asked as well. My role, Sally, as you asked, is as the professional lead for NHS planning, and that gives me the privilege of being part of many changes that can support the NHS to deliver the best care that it can for our patients. And I think that value in health is right up there with the most exciting opportunities that we need to exploit. I think that's especially the case when you see the link to digital and data and the potential for really meaningful change across so many areas of health prevention and improvement. And these things matter to people on a day-to-day basis. So my job in planning is to promote and support the service to make both local and strategic changes and to promote the value work in Welsh Government and with NHS planners across the system. And as you may know, we do that through the NHS planning framework, which is issued annually as the Minister's direction to the service, but also jointly through the Value and Sustainability Board that Nick mentioned earlier. So my team and I use our regular meetings with NHS partners to share learning and to encourage the implementation of value pathways and approaches. And I'm mostly heartened to hear that there's a lot going on, albeit probably not quite at the pace that we would want to see. I think clinical networks are also something that we can look to in the future. I take a keen interest in clinical networks since the establishment of the NHS executive has brought those into my remit of work. And I'm working with Nick and Mark Dickinson to ensure that we have the right balance and engagement across Wales. One of the examples that I frequently use about how we can make a difference through planning and implementing value pathways is diabetes. There are clear opportunities to prevent or identify early risks, to keep people well, and to head off some of the very serious and life-impacting consequences of the disease. And as part of that, NHS planners have licence to roam within their organisations, and I want them to use this and to see more of this work being pursued. We know that quality and value is important to patient experience and outcome, but also it saves money as well. So planners can help this into reality through their strategic and operational planning, and I know that this is underway, albeit at varying speeds across Wales. We also know that the Minister is really keen that these pathways are implemented, and this year's planning framework will mention the diabetes pathways as an excellent example to follow. But the work on heart failure, orthopaedics, etc. is also fantastic, and we need more discussions like today to highlight the benefits of implementing this consistently across Wales. And just finally, Sally, I think the Chief Scientific Officer's recent report on the NHS in 10 years' time highlights just how important this work is to head off some of the significant trends that we're starting to see emerging. And the value work is essential to change the course of these very avoidable outcomes. So I'll leave it there, and I know that you'll want to pick up with Jeremy as well. Thank you.
Thank you, Samir. Gosh, lots in there. So I've got lots of questions already. Jeremy, you're Director of Operations, and I know very interested in the performance of NHS Wales as a whole. It would be brilliant to hear your reflections on how you feel value-based healthcare might support that agenda and how we might widen it out, I guess, from perhaps a traditional look at things like referral to treatment time and 4-hour waits in emergency departments. Important those things undoubtedly are. Thank you.
Good. Yeah, well, not a graffiti artist or a rugby player for England, but there's only one of me, so I'll go straight into it. So, look, I think the value work has shown where we can realise some opportunities, and I'm probably going to rehearse things which you've heard from Nick and Simia now, because we haven't practiced this. But I think it shows where we all are in our sort of roles, that we're probably going to say similar type of things. So even before the pandemic, healthcare and population health in particular was subject, like many areas in our everyday life, to the volatility, uncertainty, complexity and ambiguity. So, just embracing that, it's a challenge, isn't it? So I think what value does is allows us to bring clarity, in terms of that sort of key component of compassionate leadership. We can say what we want from the system, what the system should look like, and how we should deliver services. But I think the next stage now, and probably where my thinking has gone to this, is we need to mainstream that approach. It's not about creating new structures and competing in a complex landscape. I think it's about the value work being part of the NHS Wales architecture, being a pillar of NHS Wales. Wales is a real opportunity to be brilliant at a number of things. We need to leverage the advantage of how close political decision makers and government decision makers are to the service. It can feel that we are close sometimes, but we need to embrace that, and that should be a good thing. We did many good things during the pandemic because of that closeness and the way we work together. So we need to leverage that. We can be agile, adaptive, make things happen a lot quicker. Nick mentioned that bureaucracy. I think value has shown where we can sort of break through some of those. And as Samia said, our architecture is unique. We've got statutory duties to plan for population health. We've got duties to ensure quality and candour are keystones in our work. So that's something which is unique to us, and we need to sort of, again, take that on and see where value can play a part in that as a key pillar. And as Samia said, as an enabler for change, there's lots of change we need to make. And we all go off and do it in 100 ways. And that's why we've got this unwarranted variation people hear of, and is a key feature of the work. So, the operational delivery teams I speak to, the discussion we have with them, we need for them to see the value work to be a key enabler for change and the change of services, and with support from the NHS exec as well. Then how does someone like me receive assurance and reflect that demonstration that our organisations and NHS Wales is delivering on these plans? I'm interested to see how the public see that. If you read complaints or see the mailbag of elected officials, a lot of that from the public is high satisfaction with the NHS, but they normally ask about how long they wait for services, how well they're communicated with, what's the car parkings like, and what's the access like. So there's still a lot of those things that are really important. But again, it's very different for different people, and in our small population, our 3+ million population, there is this variation. So I think the challenge is about equality and equity, and how we turn this work, which value's got from the hundreds and thousands, into an impact for the hundreds of thousands and the 3 million population. Thanks.
Thank you, Jeremy. So I'm going to kick off with a question. I think at the moment, and not just in Wales, but around most healthcare systems in the developed world, everything feels awful everywhere all at once. And that can feel a bit overwhelming, I think, can't it? Certainly I think that's felt by clinicians and managers, patients. We're all feeling that a little bit. And I think we can get if we're not careful, a bit of a learned helplessness then, can't we? How do we create focus and drive around some priorities in a system where everything feels quite difficult and where we need to make progress everywhere? Samir, can I come to you first on that one?
Yeah, certainly. Thank you, Sally. And I think it's a helpful reminder, isn't it, to look at what's happening internationally, because it can feel overwhelming. You know, we are still post-pandemic. We're in the midst of a cost of living crisis, and we work within a complex system within NHS Wales. So there is something about how do we understand what's happening globally, but also how do we prioritise for the population of Wales within that. And I do think there are very many aspects of our system which are unique to us in Wales and which give us the ingredients to really make for successful outcomes. So I'd start with the fact that we've got some really groundbreaking legislation. Other countries are looking to us around the Wellbeing of Future Generations Act, and that enables us, I think, to really develop a narrative for the Wales that we want. And you can translate that down to the Cwmtaf Morgannwg that we want, or the North Wales that we want. But that narrative for the long term around reducing inequalities and increasing outcomes. And then we have the right component parts beneath that as well. We have integrated healthcare organisations that go from prevention and primary care right through to acute and specialist care, and good relationships with other public service partners as well, albeit, you know, having very challenging discussions, but the system is there. And as Jeremy noted, we use integrated planning as the bedrock of our system within Wales. We've deliberately chosen not to pursue the purchaser provider split. And I think, you know, that gives us some stability and continuity as well. And we have the proximity of relationships. You can literally get all of the chief executives in one room or one virtual room, and that has to be an advantage. So there's something about us being small enough, but also being sort of big enough to be able to achieve really great things. And I think particularly when it comes to value in health, I think we have the opportunity to build almost what I would call a bit of a movement to really get behind this and to take it forward. Thanks, Sally.
Thanks, Samir. Nick, how do we create focus?
That's the ultimate question, isn't it? I think what Samir has described is that we have got the architecture, we've got the structure, we're small enough to be able to do that. I think what we need to be clear on from a Welsh Government NHS Wales lens is being very, very clear on what our priorities are and limiting those down to a manageable number, because, you know, as you say, if everything feels bad or everywhere all of the time at the minute, whereas actually we've always had an approach which is everything's a priority. So I think if we can be much clearer on what our priorities are and focus our resources and efforts on those, I think then if you get a few victories, shall we say, then morale starts to improve and people get that can-do attitude, and you start to be able to then tackle the next priority or the one after that or the one after that. So I think the onus has got to be on us centrally to set those priorities, and because of the architecture we can do that with every organisation in Wales, and then, as I say, channel our energies, resources into delivering some of those things, and let's start moving up the table, if you like, and win a few games.
Maybe you should have been a rugby player after all, Nick. No, it's an important point, isn't it, around prioritisation. Thank you for that. Jeremy, focus from your point of view.
Yeah, let me think of something different that Samir and Nick haven't said. And I'll pick up on David's question there as well. So probably one thing we haven't mentioned is the National Clinical Framework. So we mentioned our sort of architecture and the statutory and our agility and how close we all are. You know, Wales is a village at the end of the day. But the National Clinical Framework, in terms of the setting those standards and the quality statements in particular, you know, brings all the information, the knowledge, the data together, and tells us also how we should be looking at things, particularly from a service level. So I think that we've by setting those out, and then being sort of being part, and being part of that ability to pick those up, and for organisations to go, this is what it means in each of the organisations, and we know what it means on an all Wales level. But we need to make sure they're not optional. This isn't we'd like to do this and we'd like to do that. I think that's what we've got to do. We've got to sort of follow our structure and say, well, this is what we want to do now. This quality statement for cancer says this. This is what we want to work towards, and then there are many mechanisms we can check in on that. Then I think then we've all got to be geared towards it, whether that's the work of the Value and Sustainability Board, or whether that's the work in the performance framework, or whether that's the work in the planning framework. And all of this needs to come together and say, well, deliver these quality statements. So I think we've got to make some of these frameworks now real in lifetime. And I think the quality statements give us a huge opportunity there about setting those expectations and standards. But again, it's what I'm essentially saying. I think we've seen in the chat as well, and what Samir said is we've got to follow the information and follow the data.
Yeah, thanks, Jeremy. I'm really glad you brought up the National Clinical Framework, because I think it's such an important whole pathway approach, isn't it, to design services to deliver against some of the priorities in the quality statement. And it encourages a really data-driven approach, which of course is rooted in value-based healthcare, and I'll bring Navjot's question in about that in a moment. So it's for those of you who don't know what the National Clinical Framework is, it is a Welsh document of design principles with the clinical networks for what good looks like across whole pathways of care, and it's a really good document, so I'd recommend you read it if you haven't already. And Jeremy, I think you started to answer David Whaling's question here, really, which was about, I think, unwarranted variation in service quality throughout Wales, and also in the way services are developed. So of course there'll be some some warranted local variation, I suppose, in terms of geography, but really we shouldn't be doing things vastly differently, should we, across Wales. And I think David's additional question regarding tackling unwarranted variation is what's the broad guidance and steps that are being looked at to harmonise the different areas together using those mechanisms you've started to allude to. So can I come back to you, Jeremy, first, and then maybe come to Nick after on that?
Yeah, I'll probably give an example really in terms of having assurance on the service, and that it can be quite a black and white word, that word, and people, but it's essentially saying and checking in on are we doing what we said we were going to do and what we put out, and particularly organisations through their boards and public sector organisations, it's just checking in on that. And if you were to look perhaps in even as nearby as 2019 about what some of those discussions and meetings with organisations were, in that interface between government and there would have been a robust planning conversation. There would have been some robust conversations around quality of services, but there would have been a lot on sort of core access targets and things like that. Over this past sort of 12 to 18 months, we brought a lot of the quality statements in for that discussion to start thinking differently, the workforce planning, the national programmes. We haven't mentioned those yet in terms of their role in turning high-level policy into practice and supporting organisations in that. There's quite a lot on some of where the information has taken us on some safety concerns. Some maternity and neonatal around the UK has got a lot of focus at the moment. So I think that the world is changing and our world is changing. And as it's starting to integrate a lot more now, the work's starting to integrate. And look at the forward plan for next year, and the work on diabetes from Value is coming more and more into those discussions, and we'll be, so as well as having them at a clinical level, and they've been progressing that way, they're now becoming part of this architecture we describe and how they are being discussed. And I think that the visibility they will have now around the board tables of organisations, and the visibility they'll have in terms of the mechanism there, will raise the profile and raise the expectation. And Nick is right. What we don't need is hundreds of those. We need a core group of those things we want to do really well at, and then all be part of planning, designing and delivering those services. Thanks.
Thanks, Jeremy. And I think that point you've made about visibility is a key one, isn't it? Because it's what we focus on, what's really visible, that tends to get done. Nick, unwarranted variation, how do we tackle it?
So I think the only way to tackle it is through clinical engagement and clinical leadership, if I'm honest, because, you know, ultimately we've got to get the voice of the clinicians together to agree what the variation is and how we tackle that variation. So, you know, and as Jeremy's alluded to, we've had performance frameworks, performance management, a whole range of different approaches to tackling it, but it'll never work if it's just a bunch of managers going around telling everybody that you know, the variation is not good enough and we need to do something about it. I think it's about, you know, somebody's put in the sidebar about GIRFT, it's about finding the mechanisms, whether that's through work like GIRFT or the networks or the national programs, to bring clinical colleagues together to look at the data, look at the evidence, look at the outcomes that support that move away from variation into a standardization of approach. And again, I go back to the point of once you have a few successes, then it starts to self-generate in a lot of ways. So I would suggest that we use the clinical evidence, the patient experience evidence to drive conversations with clinical groups, whether that's through networks, whether that's through a national programme lens or an improvement lens such as GIRFT, to set out very clear ways forward that everybody then is bought into because they've had the opportunity to engage in the process. I mean, I think somebody's referenced compassionate leadership in the sidebar, and actually that's very much around listening and acting on what you hear. And I think if we can listen to clinical colleagues and act on that in terms of the way in which work is delivered and carried out, then, you know, we are taking a compassionate approach to delivery of a removal of variation, which absolutely fits in with the ethics of and the values of the NHS in Wales.
Thanks, Nick. So that's, I guess, a really important point around plugging the clinical leadership that we have in Wales into the business end of things and into decision making. And as you say, Cara did make the point about GIRFT, and GIRFT, Get It Right First Time, for anyone who doesn't know on the call, is an approach to unwarranted variation in care, championed by Professor Tim Briggs in England. And it's really around using data on unwarranted variation and clinical leadership to address that variation. And we do have excellent cohesive clinical leadership in Wales. We do have increasingly a lot better data coming on stream. So GIRFT is just clinical leadership and data. That's all it is, and it's absolutely part of the value-based healthcare work. I would agree, yes, Cara. So we can accelerate our own version of GIRFT, really, I think. I want to stay with data for a moment. So Navjot has said, thank you, Samir, for your valuable insights on linking value measures into planning priorities and measures. You mentioned data and analytics generally. What are your reflections and advice on aligning this data-driven approach more strongly with health board planning and the digital and BI teams in health boards?
Yeah, thank you, Sally. And I think it's a really important question. Thank you, Navjot, for the question. I've been in this job for about 6 years now, so I've seen how integrated planning has been evolving both pre-pandemic and also post-pandemic. And I also have the pleasure of reading all of the NHS plans on an annual basis, which is part of the reason I have reading glasses now. But that is a privilege because those plans are a window on each of the organisations and our communities across Wales. But there is a danger sometimes, isn't there, that those plans become beautifully written, beautifully crafted documents full of warm words, but they sit on a shelf with no real connection to delivery and operations. And where we see planning executed really well within organisations is that you can quite clearly see that they are using the evidence and the data to drive their plans. So warm words are important, but actually what's more important to me are the planning assumptions that sit behind those documents, both in terms of understanding where outcomes are for populations currently and the outcomes that organisations want to see for their populations, understanding what organisations need to achieve from a performance perspective, but within the sort of the data and the constraints of the workforce and the finance that they have available to them. So the ability to really sort of cleverly use data in a very sophisticated way, I think, to inform plans is vital, because that will enable organisations to translate their plans into delivery commitments, but also to undertake their own prioritisation in terms of how they sort of organise their resources and deploy their resources in their areas. So I think in summary for me, Sally, there's something about using data to standardise approaches, allowing organisations to benchmark their position against those of others around them within Wales, and that enables us to take an aggregated view and drive out some of that unwarranted variation that we were talking about earlier, and to really turn the curve on some of these issues, whether it's diabetes, whether it's cardiovascular, but I think without data, the plans become pretty meaningless. Thanks, Sally.
Thanks, Samir. And Jeremy and Nick, I mean, in fact, we all met on outcome data and how we might tackle outcome data earlier this week, didn't we? Jeremy, from your point of view, how can we use data in a more meaningful way? What are your thoughts on how we might develop that in the next couple of years? And can you tie that in also a little bit to the question that Samantha Davis has asked around perhaps some of the problems of cross-border data sharing? I think I know where you work, Sam, because that has been a barrier in the past, but I think we're making inroads to that now. Jeremy.
Yeah, so I've just responded to Samantha because it's not just a cross-border issue. I think even within organisations, internally, there's some parts that don't talk to each other, which you can improve on. So there's a lot of work going on in that area. And, you know, if I use another example, 5 months ago, if you had an NHS portfolio in Welsh Government and wanted to see NHS information, it was a 2-laptop solution. Now that's worked through, because we've been really clear on what the ask is, really clear on what we have to then describe to those who look after information governance to make sure that's right, and we're holding the integrity of that. And now it's enabled. So I think there's a way of getting the actual information. In terms of what it needs to look like going forward, I think if you spoke to 100 people, they may give you 100 different answers. So we've got to start getting really clear on what we want to start off with, and then what will help make the change, and then use it as a sort of evolution from there. So I know a lot of the work going into that space at the moment is doing that. It's getting the fundamentals in place, even in terms of connectivity, in terms of making sure that we've got some of the basics around being able to access data. It's definitely moved on. And I know, Sally, you're close to this work. If you see from the NHS exec perspective, all the different analytical work going on there, it's absolutely huge. But it's all very different. So the work now is trying to get some of the basics in place, and then trying to bring some of that work together, so we can see what that looks like. And I think if we do it at a service or a condition or that specific level, we'll work things through. And I think if we try to do it too much from a top level down, it won't be fit for purpose. So I think you need to build this from the ground up. Again, I go back to the diabetes work or the cardiovascular work. You know, that's a good way of visualizing what is important to clinicians. We've now got to then build it from there all the way through to see what it looks like at an organizational level. But that's how it works. That's what other systems you Navjot kindly shared the Italian experience with it. I've seen experience from other systems as well. that's what they do. They build a service by service up, and then you get that sort of ability to see the information and what it means at an organisational level. Thanks.
Thanks, Jeremy. So take-home point there I'm hearing from you is to turn the data into actionable information and make it in sort of digestible chunks, if I can put it like that, and present it in a way that's meaningful and which people can use to make decisions. Nick, I want to expand on the question on compassionate leadership. I know our colleague Dr. Olwyn Williams has put in the chat and has been heavily involved in developing this work in Wales, but how do we embed this in the culture of NHS Wales? Because it's the culture is critically important, isn't it, to help us drive forward this agenda?
Yeah, I think that absolutely. I think there's probably a couple of things, and there's some mechanisms in legal frameworks now as well, which should probably help in terms of duty of candour, and they're trying to create that open and honest system of feedback and understanding of when people make mistakes or errors occur, that there is an ability to share and learn from that, and not, which has often happened in the past, hasn't it? It's sort of, hide behind the screen of bureaucracy within the NHS. So I think developing that open and honest culture helps in building the culture around compassion and compassionate leadership, and builds on the point I made earlier about active listening. And it's easy to say, oh, I've heard what you've said, but actually, have you acted on what you've heard? And I think we are, you alluded to this very early on, Sally, the service is under enormous pressure. The people who work in the service are under intense pressure. The culture of each and every organisation in Wales that's part of the NHS needs to take notice of that and use that and different approaches to build a sort of, I suppose, build morale and build a culture where people feel able to talk, to support colleagues, and to express their opinions and views on things without fear nor favour, if you like, so that it feels like that everybody then is in it together, and it's everybody understands the challenges and the pressure that we're all under. So I think there's a big opportunity at the minute, actually, to really build on that. In adversity quite often comes challenge and good things. So I think it's really important that we embed those principles and values related to compassion and compassionate leadership within the way in which we manage our people, so that we are seen as looking after their well-being, as well as paying them on a weekly, monthly basis. So I think it's quite a key bit of it, and value links to that, because quite often the conversations about value are driven from somebody noticing something or somebody raising a particular issue, and if we don't listen and act on those sorts of things, then we're not showing that compassionate approach to what we've heard.
Thanks, Nick. Jeremy, do you want to come in on that?
Yeah, I've been thinking about this. We often look at this from an individual perspective, or even we go from the micro to the real macro here in terms of organisation perspective. One of the key things on compassionate leadership is that clarity, and it's really hard. Nick, you made me know prioritisation. Whenever we have a prioritisation discussion, we try and put 100,000 things into 10, and then as they just become bigger and bigger topics, we never really prioritise. So I think if it's incumbent on those of us, and there's 3 of us here who are involved in planning frameworks, performance frameworks, assurance, all of those things which we do to the NHS, and ask the NHS to respond to provide that clarity. And that's quite hard. That's really is a difficult, because what can end up happening is that you ask for organisations to do this, and then if you ask them to do something, you ask them to do A, and then you ask them to do B, and it doesn't work together, and you can end up asking on a service to achieve measures that don't work together, outcomes that don't build together. And that's what I think about. We've got to think of this the whole, and to be really, that's where it connects with the value work. If we're going to be really serious about the outcomes we want for people, we've got to be really clear about what expectations we're setting, and then measure against those, and not ask another question another time, not to move the goalpost. And that's the challenge. That's the clarity from compassionate leadership. It's part of being really clear with the service and being really clear with organisations. And then individuals will respond to do the best, and particularly if that's better outcomes for their patients. So I think it's a prioritisation piece for government in particular, just to provide that clarity and not to move goalposts, and to stick with the plan and to support organisations.
That's such a key point, isn't it? Keeping our true north and holding fast to what those priorities are if we want to make progress with better outcomes for people. Thanks, Jeremy. Samir.
Yeah, thank you, Sam. And I'll be brief because I know you want to move on to other questions, but I was also going to link my comments to the question that Emma's just asked in the sidebar as well, about how do we get the basics right. And I think Olwyn's question has sort of sparked something in all of us around compassionate leadership, because we've all been keen to get in on this one. But I'm a huge fan of Don Berwick, and many of you will know that Don Berwick's one of the Bevan Commission Fellows. He gave a fantastic talk at the conference back in July, and he used to be health advisor to Barack Obama. And he does a series of podcasts which are a really good listen. And he says, the process of re-engineering healthcare is rocket science. So the reason it feels difficult is that it is simply difficult. So recognising that we are working in a huge amount of complexity, and these are hard jobs that everybody's doing right throughout the system. So value-based healthcare for me is as simple as doing the right things in the right way. And I think there is a huge amount of compassionate leadership that runs through all of that. And the other reason that I mentioned Don Berwick is that he talks very much about how do we regain that sense of joy in work, joy in what we do, because I think from there comes improvement and comes in compassion. And my only other reflection would be that we are all patients, aren't we? And many of us are carers as well. So it's about seeing it from that perspective around what are the standards and the experiences that we would expect to see and that we would want to see for the rest of the population as well. Thanks, Sally.
Thanks, Samir. And I want to ask you all a really hard question now. Because I can, and it sort of links to Emma's question. So Emma's question is: there's a wealth of positive work going on across value-based healthcare in Wales. How do we make sure we don't lose focus of getting the basics right? Linked very much to, and she uses the example of nutrition, but linking very much to prevention, building health in communities, and how we help people to live better with chronic ill health. So my question is, and it's one of the reasons that I got into value-based healthcare in the first place, which is a frustration around resources not being always allocated in the best way to get the best outcomes equitably across Wales. So the question is, we have an unsustainable healthcare system for lots of different reasons. But one of the reasons is that we are very good at rescuing people nowadays in modern healthcare, but we've been a lot less good at helping people live with the effects of chronic illness over increasingly long periods of time, whether that's diabetes, heart failure, inflammatory bowel disease, the consequences of cancer treatment. And self-management and supported self-management, therefore, for people living with chronic ill health is incredibly important in terms of improving people's outcomes and getting them to achieve their goals and experiences, goals and preferences for care and a better experience in their lives. But that doesn't happen by accident. It requires tools, resources, and interventions to support people in their chronic ill health. So how do we, in a cash-strapped NHS, make sure that we still invest in those things, in new things that really matter, that are really going to help us in the longer term, bearing in mind, we've got these short-term issues as well. So I did warn you it was going to be a hard question, so sorry about that. Nick.
throw me into the lion's mouth. Thank you. No, I mean, well, look, it's the impossible question, isn't it, in some respects, because we all know that prevention, that the fully left-hand side of the health pathway, whether that be beyond primary care into population health, public protection, changing people's ways of eating, exercising, etc., are the key determinants of whether we've got a sustainable health system for the next 50 years. But shifting money into that is very difficult because it doesn't show the instantaneous results that everybody always expects. And the focus that politicians in particular have on, instant results and showing that they're sorting things out inevitably gets focused on secondary care and the way in which that then is viewed in the system. And as a result, the population always see health as being hospitals and ambulances and nurses and doctors rather than therapists, dietitians, social workers, etc. So it's a very, very challenging question. I think the only way we can really start to tackle that is by, to some extent, the focus that I know you've described around things like diabetes or the MSK pathways, where we go right back to the fundamentals of when does this pathway start and how do we get people onto the right pathway at the very beginning, so that actually it becomes more preventative than it is treatment. And we turn lots of people round, if you like, who were on that journey for a long time. I think that's the only way we're going to do it in the current system, and the current cash-strapped system, as you describe it, is to shift as much of our pathway work and as much of our focus to the left-hand side of the approach and start to eke out results in that way, and use other opportunities that we communicate to really start to embed the message. They would be my two answers, I think. But it is thanks for the very difficult question, and the person who solves it will obviously be knighted and become leader of the free world, but it's a bit of time for that, I think. Yeah.
Thanks, Nick, and apologies for the difficult question, and thanks for being the first guinea pig in answering it. Jeremy, I'm going to bring you in now, but just to let you know, Adele thinks it's very comforting that you're not going to move the goalposts again, ever.
I've never moved a goalpost, just that some people change pitch. So,
she doesn't actually say that, to be fair.
Yeah.
I thought I'd have a bit of fun.
This is quite tactical, because I thought if you ask Nick first, then I'm going to be last again, so I'll get in before Samia. So, no, in all seriousness, not that I'm looking to be knighted, I'm not looking to solve this. It's a very challenging question. I've tried to respond to Emma there in a couple of sentences. It's a very difficult financial resource outlook for lots of people, families, communities, all public sector bodies. I don't really remember a time, and I'm pretty old, when we all went, oh my God, we got loads of money. I don't remember a time. It just is worse now, and that's quite right. So it's where the commonalities, I think, and I don't want to steal Samia's thunder here as well, but I think there's commonalities between how public service boards operate. Take the malnutrition and the nutrition element, which Emma talks about. That's just not a health thing. That'll be in education. That will be in a number of both governmental and local authority and public sector issues. So I think there's getting some common priorities there. I think also the big challenge the big opportunity I think we've got, which is a challenge as well, is that recognizing how we're going to change some of this. And if you look at some of the Scandinavian countries, and Jan Williams, the chair of Public Health Wales, said at Team Wales, she was really interested in how their approach about making a commitment about how much goes into prevention and setting that out. So there may be something we can learn off others, but really adapting it. Taking Nick's point, the political cycles can sometimes determine that we focus on things in 1, 2, 3, 4 years. So that's a challenge, but longer term commitment to that. Today, whether we make any decisions today or tomorrow, there will be people utilising the NHS and they will get a service. So it's about acknowledging that, I think, and then going, right, what do we need to really focus on here? Do we need to do more with our children and younger adults? We tend to focus an awful lot on the illness pathways. But are we doing enough up front there? Because we talk a lot about illness and frailty and growing old, and that's really, really important. I'm not part of the conversations an awful lot on the wellness part and the preventative part and what we're doing at the children element. Certainly from a performance framework, a lot of it is about adults and older people and their experience at the back end of the pathway. So maybe there's something in that about how we're putting the same level of energy, focus and attention into the earlier years, and doing that integrated. Now, I don't mean integrated between primary and community, but doing that between education and health and those other departments. So yeah, that's my answer. I won't get knighted for it, but hopefully it's good enough for this morning.
No, I like that answer though, because it brings so I absolutely think value-based healthcare is a vehicle for what you've just described, and marrying up what you've just said with what we were talking earlier about focus and priorities is a really helpful way to drive forward what we've previously found difficult to do, even though we know it's the right thing in our hearts. And Samir, planning's critical to that, isn't it?
It is indeed, and I was thinking about my dad. Bless him. He had Parkinson's, and the only way that he could access community support in England, I note, was through an acute admission. So it was only when he was so unwell that he would then be able to access the services that he needed in the community, which would then hopefully prevent a further admission. So there is something about how we pull all of this forward, and how we focus on prevention, keeping people well and safe in the community, and trying to avoid many of those admissions which were probably preventable. And just thinking about Emma's question, there was quite a bit of criticism a couple of years ago around Wales is not doing enough around prevention. There's not enough happening, and we routinely scan NHS organisations' websites, Facebook feed, Twitter feeds, to see what's going on. And it struck me there is a huge amount going on. Some brilliant examples of dietetic teams doing outreach schemes with local schools. Philindra's doing some brilliant work with schools and with the community around prevention and healthy eating. But a lot of that happens under the radar. And it's almost as if these are initiatives rather than being built into the core fabric of what we do. So I think something just about normalising those activities and building them into our pathways is really important. Thanks, Sally.
Thanks, Samir. And I think that's a great point to end on, because I think value-based healthcare is the great integrator, because it does encourage us to do that whole system, whole pathway thinking, and to integrate those initiatives into business as usual. And actually, to finish on a point of hope, I would like to think for everybody, if you go around the world looking at other healthcare systems, some of which may on the surface appear to be performing a little better than Wales at the moment, they do, however, have hugely fragmented systems. And when you dig underneath the surface, there's a lot of other stuff going on. And we do have this amazing advantage of having an integrated healthcare system, don't we, in Wales? And we really need to capitalise on that, I think. So thank you so much for taking time out of your busy schedules and putting yourself on the line to answer hard questions in a difficult time in the NHS, and for all of your reflections on the opportunities that value in health might bring us in NHS Wales. Thanks again, Jeremy, Samir and Nick. And thank you to the audience. So this is our last session for Value in Health Week. They are all being streamed on YouTube. They have been edited, so I think most of them are available on YouTube already, so please do avail yourself of those, and we will be back in the new year for our regular monthly healthcast as usual. Diolch yn fawr iawn.